Hello, and thank you so much for joining us. I'm Shari Einhorn. You're watching Your Health Matters on Sun 20 TV. We've got a great show for you today, and my first guest I want to introduce you to is Dr. Seth Korbin. Dr. Korbin, you are an orthopedic surgeon and vice chairman and director of joint replacement at Stony Brook, Southampton Hospital.
Yep. Thank you for having me.
Thank you for joining us. This is a really big topic. I think everybody probably knows somebody that maybe had a knee or a hip replaced. I think there was an increase in the number of hip and knee surgeries from 2020 to 2022. The number I have is 18%. Does that sound accurate?
I think that sounds actually pretty accurate. I think the numbers over time have just been going up and up. And I mean, you can see, our Orthopedic Academy puts out some projections of hip and knee replacements over time, and it's sort of going up exponentially.
Why is that?
I think it's probably a couple of different reasons. I think one, as people, I think we are just higher demand in the sense of like what we expect in our day-to-day life. So I think people are just doing more, they're more active, and the expectations are generally just higher than they probably used to be. I think, there's some other factors too. I think, as a population, we probably are carrying more weight than we probably should. And so that does lead to a little bit extra pressure on the joints and potentially, needing a joint replacement, earlier on in life.
So why don't you take us through actually what is joint replacement? You can start with hip, transition to knee, or vice versa, whichever way you want.
So, I think the hip replacement itself is very much sort of what the term actually, says. It's really a replacement. And so what we're doing is, the hip is a ball and socket joint, so it's fairly simple. And what we're doing is we're preparing the socket. In essence, we're taking the arthritis or the cartilage, the remaining cartilage that's there, away. And then we're basically resurfacing the inside of what they call the acetabulum or the socket. And then we're putting a metal component into that area. And the socket is made out of metal, but it's designed with a special bone ingrowth surface so that your bone actually grows into it over time, and so that it becomes unitized or one piece. Inside of that socket, we put a plastic liner, which is one of the bearing surfaces. And then on the other side, which is where the ball is, we basically take that out because that's arthritic too. And we put a component or a prosthesis into the femur or into your thigh bone. And that also similarly is metal and has an ingrowth surface into it. On top of that, we put a ball, which is made out of ceramic. And then it becomes, once again, a ball and socket joint with the ceramic ball articulating with the plastic insert.
So let's do one procedure at a time. So this one, are there specific people that might be better candidates or less good candidates for hip replacement?
Certainly healthier people are better candidates, people that are more active, but ultimately there's, the whole range of patients out there that potentially could benefit from a hip replacement. And I think, diagnosing someone is probably the first thing, either, radiographically and then also on, an examination in the office. But once you've identified those people, then, and it's the right thing to do, then you're going to offer it to them.
And so take us through the actual procedure, let's say day of and rehab time afterwards and do's or don'ts.
So I think that, in general, the rehab time, it's variable because I think each patient recovers differently from surgery. But, ultimately, you're probably talking, some people can go on an outpatient basis after the surgery the same day and go home. Other people may stay, a night or two in the hospital. But in general, the recovery from a hip replacement is really good. I think that initial recovery period is probably in the first 2 to 6 weeks. And so by 6 weeks, people are kind of back to doing, things that they, kind of normally do. Is there further recovery? Yes. Sort of a more complete recovery from a hip replacement is probably somewhere between, 3 and 6 months.
Okay, let's transition to knees, right? So I think a lot of people probably know somebody that had one knee replaced, double knee replaced, but there are also varying degrees of it, right? Not a full or partial, and this is just conversational. So take us through what the options are.
So, on the replacement side, there's what they call unicompartmental replacements or arthroplasty. And that's where we basically replace one particular compartment in the knee. And so there's 3 compartments in the knee. There's sort of the inside or the medial and the outside or the lateral part. And then there's also what they call the patellofemoral compartment, and that's where your kneecap is. And so we can, if we identify, specific areas that are, then only those areas that are affected, you can do a joint replacement in those areas. And so it's still a replacement operation and it's still a large recovery despite it only being a partial replacement.
Okay.
But I would say on average, the majority, actually more than the majority, probably 90% of patients end up with a complete replacement, because by the time they've come in and you actually see them and you look at their radiographs, they probably are in need of a complete replacement.
And again, similar questions to the hip replacement. Anyone a better candidate or a worse candidate? Is it more common in men or women?
Actually, I think it's more common in women on that side. Candidates, once again, I mean, it really depends on your overall health, and so sort of what you're bringing to the table is just as a patient. People that are more active obviously probably tend to do better after surgery. They just can get through the recovery more quickly. That being said, you sometimes find in the younger patients that you do, they do struggle a little bit, because I think that their immune system is a little bit more robust than you when you're 70, 80, 90, that kind of thing. And so you do tend to form some scar tissue early on if you're younger. And so you have to fight through that with a little bit of, the rehab, I think.
And take us through sort of the diagnostic process. If somebody comes in, how quickly or how easily is it to diagnose somebody who needs either the hip or the knee?
It's actually pretty easy. A lot of times people actually come in and they actually tell you their symptoms, and based on those symptoms, you kind of already have an idea of what they're telling you. They may, for hip-sided things, they may say, oh, I can't put on my shoes and socks. On the knee, they say, I have trouble putting pressure on it or standing for long periods of time or even going up and down stairs. And then, once we have that history, we're going to get an x-ray in the office and we're going to look. And just from the x-ray alone, typically you can diagnose people whether or not they need a joint replacement.
Are there other options if people don't want to go through that surgical procedure?
Well, I think that no matter what, you're always trying to get people to try conservative management, right? You want to do the least invasive things first, especially if they haven't tried them before even jumping to surgery, unless, the arthritic disease is so advanced that you really have no other choice. But of course, doing as much conservative sided things is the right thing to do. So if they haven't tried anything, then there's things like oral medications, physical therapy, potentially activity modification, and then we can potentially do injections either in the office or with a radiologist, especially if it's in the hip area.
Oh, talk about the injections, because I think perhaps that's something that people talk about also. People get cortisone shots. Sure. Or gel, I think. Yep. We've heard about for knees.
Yeah, and so I think on the there's different injections, and there actually is more than that out there now. But I think probably the most researched things are probably cortisone, as well as the gel injections, or what we call viscosupplementation. And the injections can be beneficial. I think patients do pretty well with them, if given for the right indication. And most of the injections are given in the office. It's not a cure for the arthritic changes that you have, but it's sort of symptomatic control, right? So if you can give the injection and potentially put off surgery or a joint replacement for some period of time, and it allows you to go through your day-to-day, then it's worth trying at least. There are some risks and some side effects, and this is something I counsel patients in the office, is that there is a small risk of infection. Mm-hmm. And then the other risk is that we've found out over time that if we give, say, a cortisone injection, if we end up doing a surgical replacement, that potentially we can actually have an increased risk of infection in the prosthesis. So we actually have to wait a period of time, potentially about 3 or 4 months. And that's so before I give anybody an injection, I counsel them on them and say, hey, listen, if you want to come back to me in a month from now and want to get a joint replacement, we can't. So that's a timing thing. That's a sort of a discussion that I have with them, and just to try to give them as much information as possible.
Are the injections available for more than one dose? Like, can you have multiple cortisone shots or multiple, I'll call it gel shots? So
the cortisone injections are just one injection. We repeat them approximately every 3 months or so. Mm-hmm. And you can inject both knees, but typically I do one. If you have a history of diabetes, then definitely one. We have to be a little bit careful with that. It can sort of transiently elevate your blood sugar. On the gel injections, they do manufacture different injections. So you can have a one-shot injection, or you can have a multiple, sort of like a 3-shot injection where you come back every week to have the 3-dose regimen.
And I'm curious, so talk a little bit about the timing and the age of patients. Are there people that have had a hip replacement perhaps when they're younger and then again when they're older, and the same with knees? If you have one earlier on, will you potentially need one later on?
So I think, yes, I think that's true. So, I mean, the joint replacement itself has a lifespan. And I think traditionally we talk about it lasting about 20 to 25 years.
Oh.
Some of that's a little bit on old data. And so, we talked a little bit earlier about the bearing surface being plastic. And that's where we had a lot of problems where that's where the wear would come from.
Okay.
And so we've done some things to the plastic in the manufacturing that has made it more robust and actually last a bit longer. So that data, since that plastic's been out, it's not really there. We have like midterm data, but not long-term data. So it's possible that the joint replacements will actually last longer. But that being said, if you do get one early, either a hip or a knee replacement, you're looking at potentially having a revision, so an additional operation in your lifetime. And that could be one or two, and that depends on sort of what the problem is over time.
And obviously this depends on the patient, but overall, are people able to get back to, I guess, not where they were because they probably weren't in a great place if they came to you,
right.
But better than, back to sports, back to physical activity, better than they were?
I mean, I think that, especially on the hip replacement side, I think people do really, really well. It's, it's termed the most successful surgery in the world because people do really, really well from it. So I think a lot of people on the hip side get back to doing a lot of their activities. I think on the knee side, I think that's a little bit more challenging. So I think if you're a very, very high demand person, you're really looking to get back to like high intensity sports, I don't think that those patients will be all that happy with it. But, if you're the person that's, swimming, playing tennis, playing golf and things like that, I think people actually do better. And some studies have actually shown that over time that people are happier and they do better in their sports.
And what are you seeing as far as patients coming in your particular practice? Older, younger, varying degrees?
I have a mix. And so I think, my practice varies. I do practice out here on the East End, but I also do practice up the island at the University Hospital. And so you're seeing different degrees. I think the population out here on the East End is actually a little bit different than the rest of Suffolk County and Nassau County. I think overall the group is healthier out here. They're more active. They're more engaged. But I think we see the whole gamut. We see people that are 30 years old that need a joint replacement, and then we also see people all the way up into their 90s. So there's different reasons why you might need a joint replacement, especially earlier on.
And I think we just want to be really clear, right? If somebody thinks they need one, it doesn't mean you're going to go in and schedule it, right? There's counseling, there's things that happen, a timeline.
Yeah, and a joint replacement surgery is an elective procedure, and I explain this to my patients all the time. Mm-hmm. It's not something that you make a decision that day or even have to make the decision that day to move forward with surgery. It's something that you need to consider. You need to talk to family, to talk to friends, to sort of get an idea. You need to look into, is there other conservative treatments first that you should do before the replacement? And so, it tends, I would say 95% of the time, it tends to be you just are having a conversation. But a lot of people actually know why they're coming to you. They've either seen somebody else or maybe had some x-rays or they know their symptoms or they have friends that they've had a joint replacement like, hey, you got to go check this out. So they're kind of already prepared coming into the conversation, I think.
Also need to make sure you have time for recovery if you're working,
Correct.
Right? Things
right.
like that.
Time,
right.
Time off from work, sort of preparing your house and making it sort of amenable to the recovery.
Oh, good point.
So there's a lot of things that go into it, and I think people take that for granted sometimes. It's not just the carpentry of it, it's all the other stuff that you have to plan before the operation and then that you're also figuring out after the operation.
Okay, Dr. Korbin, thank you so much. That was a great source of information. If you want to get in touch with Dr. Korbin, we're going to put a phone number up on the screen so you can make a phone call and see if either of these procedures is right for you. Thank you for your time.
Thank you for having me. I appreciate it.
We appreciate it. And when we come back here on Your Health Matters, we're going to learn more about rehab services. Stay with us. Welcome back to Your Health Matters. I'm Shari Einhorn. We're learning about rehabilitation services, big topic for a lot of people. My guest now is Craig Holmes, the Director of Rehabilitation Services at Stony Brook, Southampton Hospital. Craig, thank you for joining us.
Thanks for having me.
So why don't you let's start from the beginning, as they say. What are rehabilitation services in general?
In general, rehabilitation involves once a patient has some sort of injury or illness and they're trying to regain function that they may have lost as a result of that injury or illness. So therapists are able to offer professional experience and advice on how to go about regaining that lost function.
I think people may be familiar with terms physical therapy, occupational therapy, speech therapy. Those are maybe the three main ones, right? So do you want to take us through, let's start with like physical therapy. Sure. What is that? What does it encompass?
A lot of times people confuse, I think, physical and occupational therapy because there is some overlap there.
Yep.
So the most general description or way to describe the difference between the two that I would give is that physical therapists function and focus more on gross movement. Occupational therapists maybe function more on fine movement. You'll see physical therapists focus more on range of motion and strength and gross motor, whereas occupational therapists might focus more on upper extremity and hand and fine motor skills. Occupational therapists also typically focus more on activities of daily living.
Okay, and so I have sat in on a couple of sessions just throughout the years of doing health stories. So physical therapy may be walking, lift, stairs,
Sure.
sitting, things like that, right? What are some other examples?
Sports. I think a lot of people's image of what physical therapy is related to sports injuries and recovering from those. But we see patients from pediatric all through geriatric with every diagnosis and condition that you can imagine.
Okay, and when you say occupational therapy, we're talking about fine motor skills like maybe zippers, buttons,
Sure.
writing. Give us some
And we
examples.
think of activities of daily living. We're talking about dressing, we're talking about bathing, we're talking about skills like that. And again, our team at the hospital also specializes in hand therapy. We have certified hand therapists, so their focus is upper extremity and fine movements of the hand.
Okay, and speech therapy, and then we'll go back through a lot of them.
So speech therapy is very broad. Speech language pathologists help patients who have communication issues, whether as a result of a neurological condition like stroke or MS or something like that. But they also might see children who have delays in communication language issues.
Okay, and so let's say somebody thinks that maybe they need therapy in one form or another. Do you need a referral from a primary care physician? Does it depend?
We require a referral from a physician. The law does allow for patients to be seen without a prescription for a limited amount of time. However, most insurance companies don't cover it, so we do recommend that patients get a referral.
Okay, and typically how long, and I'm going to say typically, and you're going to say it depends
no
on it depends on the patient as I ask the question. I think people sometimes feel like PT is 3 days a week or whatever. How does one know
It
how often to go?
entirely does depend on that particular patient and the reason why they're coming for treatment. So we do have patients that come 2-3 times a week. We have others that might come once a week. It really does depend. There is no standard answer. If there's a standard answer, it's probably the wrong answer. So it's based on the individual.
Okay, and length of time, duration of therapy?
Same. Some patients may come for 2 weeks. Others may come for months at a time. It really depends. Some conditions you can walk in with symptoms and walk out with relief. Others it takes time. It's a commitment.
So talk about that part of it, because I think we live in a world of instant gratification, and people say after 2 times of seeing a therapist, I'm not cured, right? Can you expand on that a little?
Yeah, it's a matter of managing expectations. Injuries don't recover in 1 or 2 visits. They take time. A lot of the patients that we're seeing have chronic conditions, progressive disorders and conditions that they just don't heal and recover from in a few days. So, and that's one of the important things that therapists will do, is communicate what patients should realistically expect from treatment, what the patient's role is in their recovery, what the therapist's role is, and what realistic expectations should be.
Is therapy the kind of thing where I go there 1, 2, 3 days a week and then I do nothing the rest of the week?
No,
Okay.
Not if you expect to do well and recover. Patients are typically going to be given a prescribed home exercise program, whether it's PT, OT, or speech therapy. They're only going to get an hour or so a day, a couple of times a week maybe, with us, and it's really what they do at home in between those visits that makes all the difference.
So the patient has some responsibility when they're not
Yes,
actually in therapy.
they do.
Okay,
It's not something that we do to you, it's something that we help you do on your own as well.
is that sometimes something that comes up because?
Yes. Yes, it's an issue because there are patients that expect to just come and they might think it's going to be a bit of a spa treatment. And that's just not how it works. And it's why it's so important that we make sure that the patients have realistic expectations and they understand that they're going to have to be committed to their recovery and they're going to have a lot of work to do on their own.
Tips for finding a therapist that works for you. I mean, sometimes there's personalities that just don't click, right?
Sure. Personality is definitely a part of the equation, but I think it's most important to find a therapist who has experience and who has time, who's going to listen to you and spend time with you. A lot of facilities and clinics, the patients are booked 2 and 3 and 4 at a time. We don't do that. Our therapists have time to spend with their patients, so they actually get to listen to them, put their hands on them, and work with them and supervise them directly.
And how can patients get in touch with you, and who's eligible to be treated by your practice?
Patients can call the numbers that they're probably seeing on the screen. They can look at the hospital website if they need to find those numbers elsewhere. Patients who have a referral from their physician come and see us for a variety of conditions. It can be anything from orthopedic to neurological to geriatric conditions. There's an awful wide variety of diagnoses that we can cover.
You mentioned sports injuries before. That's a huge component, I'm guessing, and we talked a little bit about that with our earlier guest. What kinds of sports injuries do you see? Are you seeing anything more than others in older or younger athletes?
We see everything. We see everything from the sprained ankle from the 14-year-old, in a lacrosse game to what we're seeing more of lately, it seems, is older people with pickleball.
Oh,
injuries,
interesting.
the elbows and the shoulders. So we see a bit of everything.
And so is there a difference in treatment for older versus younger patients?
Yeah, there's a difference in treatment for every individual. There is no such thing as, you're this age and have this condition, so this is the treatment. There are guidelines for sure, but it's really based on the individual and what the therapist sees during the initial evaluation.
Is sports rehabilitation different than another kind of physical or occupational rehab?
Yes, in that what you're trying, the function, the loss of function that you're trying to address is sport specific, whereas for somebody else it may be something as simple as being able to get in and out of bed on their own and be able to walk up and down a flight of stairs or walk without a walker or cane. So it's really the goal and the focus of the treatment that's different.
Anything specific that you see further out on the East End? I know in other shows we talked about how sometimes people come out, may not be used to such an active lifestyle and attempt to do things that maybe they haven't done in a while, like maybe riding a bike, and perhaps suffer an injury and need rehabilitation.
Yeah, I mean, a pretty standard patient, especially in the orthopedic setting in the rehab field, has always been the weekend warrior who, is playing sports and things on the weekends that, they're not maybe prepared for. They get the typical kinds of injuries that we all get as we get a little bit older.
And so do you see more of that during the summer on the East End?
We see a bit more of everything in the summers. Our volume definitely grows as the population swells, so we see a bit more of everything. I wouldn't necessarily say specifically of the orthopedic variety, but a bit of everything. We see more of everything.
And how did you get into this anyway?
Myself personally?
Yeah.
At the time, it was certainly a very growing and talked about field. I also had some personal family experience with exposure to it as a career, and it seemed like a great direction to go in, and glad I did.
And what can you tell patients who may be worried about going for any kind of therapy, whether it's sports, physical, occupational, or speech? Maybe it's just a little bit out of their comfort zone.
There's nothing to be worried about. Our staff specifically, they're well trained. They have lots of experience. They're not going to hurt anybody. And if you have a reason to be considering pursuing treatment, you should.
And people see results is the point you want to make, right? It's a process.
It's a process, but like I said earlier, it's not something that you come in and we do something to you and you leave better. It's something where we help guide you through the recovery.
And the hospital has a new cardiac pulmonary rehabilitation program, yes?
We certainly have one. It's not new. We've had that program for many years. That program is at the hospital. We do cardiac and pulmonary rehab, phase 2 and phase 3. So we have cardiac patients who've recently had heart attack or transplant or valve surgery who are in their early stages of recovery, and they're exercising under the supervision of an interdisciplinary team of nurse practitioners and registered nurses, exercise physiologists and respiratory therapists. In that initial phase, they're typically on a telemeter, so their EKG is being monitored throughout the course of their exercise program. They're also receiving secondary preventative education in things like stress management and medication management and nutrition. So it's a very broad and loved program. We have patients who have graduated out of the phase 2 programs in cardiac and pulmonary that go into our maintenance programs. We have some who have been with the program for 20 plus years.
Wow.
Because of the security that they feel being able to exercise in a supervised and safe setting.
That must be very rewarding to see folks that long term.
It is, and I think it's a great example of the community hospital role. Because it's almost, my office is right across from cardiac rehab, so I get to hear the voices as they're coming in every morning, and it's a club. It's people who have known each other through this program for years and years at a time, and they're committed to the program. They're committed to the program because of everything it offers them, but also because of the relationships that they form with the staff and with the other patients.
You mentioned the community feel is also, so there's a new speech therapy program department at the hospital. Can you talk about the ties to the Stony Brook Southampton campus?
We've had speech language pathology services at the hospital for a very long time. The difference is that in this past year, we've partnered with Stony Brook University at the Southampton campus for their graduate speech pathology program, where the hospital will now, going forward, be the primary clinical site for their students' training.
And how does that program work?
So the hospital employs a staff of speech-language pathologists, and the students will be rotating through the hospital over the course of their education. I think that they're at the university for 3 years. They'll be at the hospital year-round throughout that time, learning from the hospital staff. They'll be able to observe all of the latest treatments and protocols, and it's a great opportunity for the students to learn and also for the hospital to play a role in educating the next generation of speech-language pathologists on the East End.
Okay, Craig Holmes, thank you so much. A lot of information to digest. We're going to have phone numbers up on the screen. If you're interested in any of the therapies offered, make a phone call, and just remember it's a process, and part of the responsibility also falls on the patient, correct?
Absolutely.
Thank you so much for joining us. We'll see you next time on Your Health Matters.
Funding for Your Health Matters is provided by Stony Brook Southampton Hospital. As part of the Stony Brook Medicine Healthcare System, Stony Brook Southampton Hospital is committed to providing world-class academic-based medical care to our entire East End community.